Minneapolis-St. Paul, bringing unity to the community. 89.9 KMOJ, the People's Station.
Welcome to Community Health Dialogue, sponsored by North Point Health and Wellness Center. The views and opinions on Community Health Dialogue are not necessarily those of the staff, management, and board of directors of 89.9 KMOJ. Now here's your host, Clarence Jones.
Good evening, Twin Cities. This is your host, Clarence Jones of Community Health Dialogues. And as you probably know by now, this is an extended version. This has been a series of conversations that we have held thanks to Dr. Wendy Hellerstedt at the University of Minnesota School of Public Health, Maternal Child Health Division. And she's been working to provide me with some wonderful speakers to come into the community and talk about issues that impact our community, but also impact the health of our children. And so tonight we are honored to have the Commissioner of Health, Dr. Ed Ehlinger, who is here, along with Mr. Michael Shalmer, who is also with the Communication Director of the Minnesota Department of Health. They're here, and they're going to talk to us about some things. I already told Dr. Ehlinger I'm a prober, so I'm going to ask him a whole lot of questions because I think there's a lot of things that he can share with us. Since he said that the last time he was here, KMOJ, at KMOJ, he was at the Glenwood site, so we know that's been a long time coming. And so we're going to try to figure out ways to bring him back here so that he can talk with our community about the issues of health and how do we get optimal health. And so welcome, gentlemen.
Good evening, Clarence. Good to be here. And it's nice being back in this community because I've worked on the north side for many years. I worked for the Minneapolis Health Department and actually started a clinic in the Glenwood-Lindale neighborhood, which eventually was taken over by Pilot City, now North Point.
Yeah. Which just happens to be the sponsor of our show.
Exactly. So this is like coming home.
Well, excellent. And then you also told me that you went to the Capri Theater and all those kind of things.
I had season tickets for the Legends of Jazz.
Okay.
So I love Broadway. It could be even a more booming place than it is. So let's keep working on that.
Well, great. And then we'll find something for Mr. Michael to do over here as well. So thank you both for coming, though.
Thank you. It's great to be here.
Yep. So one of the things that with this particular show, one of the things that we are trying to do is to engage people in the conversation around public health. What is public health? And the reason for that is because I feel like when it comes to health, most people look at the biomedical portion of health, which is I go to a doctor or I go to a dentist, and that's my full intent or extent of public health. But Commissioner, why don't you explain to our listeners what and how you define public health?
Well, first of all, let's talk about health.
Okay.
Because I think when we talk about public health or medical care, we have to think about what are we talking about in the first place. And health is more than just the absence of disease or injury or disability. It's actually complete physical, mental, social well-being. And it's the ability to use the gifts that you've been given to really make a contribution to society, to really maximize your enjoyment of life and everything that's in it. So it's really a broad definition. So what public health is not just that physical and mental absence of disease or disability. That's where medical care comes in. It actually treats diseases and disability. Public health, in the definition, is what we do collectively as a society to assure the conditions in which people can be healthy. So public health focuses on the conditions that help people be healthy. So it focuses on the socioeconomic environment, the physical environment, the economic environment. It focuses on relationships between individuals and communities. It focuses on whether or not people have jobs. It depends on whether or not people have clean air and clean water and clean food. Those are the factors that go into public health to protect and promote and maintain the health of individuals in our communities.
You know, Commissioner, I'd like to continue that line of conversation because I'd like for you to drill down a little bit deeper into this whole idea about various types of public health that people see on a regular basis, but they don't realize that it is public health. For example, we talk about the street lights.
Mm-hmm. Yeah. The built environment really impacts health. If you live in an unsafe community because you don't have enough street lighting, for example, you're afraid to go outside because you're afraid of what might happen. That affects your health. It's a stress on your life, and it keeps you inside, and it keeps you from exercising and interacting with your community and relationships. So those things are certainly factors. How we have our streets, if they're safe to walk on and bike on. We talk about complete streets, where you can have public transportation and automobiles and biking and walking. That's all about public health. How our cities are designed. So airflow and traffic flow through cities is all about public health, because if you don't have good traffic flow, you have increased buildup of air pollutants. And also, it also makes it unsafe to walk and bike and those kinds of things. Architecture is really a public health issue, because how people access all of the curb cuts and automatic door opening is all about giving people access to their environment. Those are all aspects of it. Certainly we think about food. We want safe food, so the inspections of food, the growing of food, the maintenance of the safe food is a public health issue. Same thing with water and air. All of those things are part of what we look at in terms of public health interventions.
And I'm glad that you mentioned those, because that's one of the things that we're trying to do, is to expand this conversation around exactly what is public health. But I want to ask you this other question. We know how doctors and nurses are created. How do you create public health professionals?
Well, when I became a physician and I went into practice, I started seeing patients in my clinic, and I realized that I could see 20, 30, 40, 50 patients a day, and I could do a really good job of treating each one of those individuals, but it wouldn't make a whit of difference in the overall health of the community. There were too many other factors: too much smoking, too much obesity, too many injuries in the workplace, too much alcohol use. I realized that I could not treat that community into health, that there had to be another way of doing it. So I started thinking, what's another way of doing it? So from my clinical practice, I realized the things about public health. I think other people get at it from recognizing that they want to make a difference. People want to make a positive difference, and they start saying, how can we make that difference? And they start looking at, are there programs that I can get engaged with, or can I start to be engaged in policy development, recognizing that policies make a big difference? And they start thinking about that, and all of a sudden they realize, oh, we're part of a whole group of folks who are changing the conditions in which people live. And they realize that's what public health is all about. And I have to let people know that public health is not a place of employment. Public health is a philosophy that you take in your everyday life. Yes, there is governmental public health. I'm engaged in governmental public health. I work for a state health department and governmental public health in the city of Minneapolis Health Department. But there are people like yourself. You don't work for a governmental agency, but you deal with public health because you're looking at the conditions in which people live, work, play, and go to school. You can be a public health person as a teacher. You can be a public health person as a sanitarian, as a sanitation collector. You can be a public health person as a physician if you take that view that we can prevent disease, that we can help promote health, and that we can work on the conditions that create health.
There's a lot of young people that listen to our program, and I would like to have you give them an invitation to become a public health worker or official, because I think personally, and I've said this many times on the radio program, that if I would have known about public health when I was younger, I would have jumped into this thing a long time ago, because of the opportunities, because of the real impact that you can have. But I think that it would be nice for you as commissioner to extend an invitation to some of the young people to join the public health band.
Well, yes, and I will certainly do that, Clarence. But again, public health is not a place of employment.
Okay.
But there are some activities that relate to public health. But everybody in our community, everybody in our society should be concerned about public health. So they should know about public health. They should know that how our cities and our countryside is put together, how our programs are put together, how schools are put together, how our government is put together, all impacts public health. So they need to be engaged in civic activities. I tell all of the professionals, you have two roles. You have your professional role and your civic role. And your civic role is really about public health. It's really about creating the conditions in which people can be healthy. certainly on a professional level, there are things that you can do. You can work in the field of public health with some training in public health. You can work for governmental public health, or you can take a public health perspective in your job in health plans or in hospitals or insurance companies or in schools. But I want everybody to be engaged in public health, to know what it is and know that they have a role to play in that.
I like that because I think that even going down on the street, picking up paper off the street is a public health issue. I mean, I think even sometimes speaking to people as you're going past them is a public health issue. I mean, it's just a part of making people feel like they're part of the community. And I think that's one of the things that we want to make sure happens. We are a community, and we have to understand that we all have a role in it, and that we all actually have a part in making it better.
Yeah, I don't know of any person who is not part of the public health field.
Okay.
I mean, everything that if you do it with the idea that I'm trying to improve the community in which I live,
right,
that I'm trying to make life better for my community, whatever you do with that frame of mind, you're helping the community get better. So that's why I always think, one of the issues I'm sure we're going to be talking about is disparities.
Sure.
and health equity. And I'm saying, whatever you do, look at what you do in your job, whatever your job is, with that idea of what is this going to do to reduce disparities? Because we know that if there are big disparities in our city, in our state, that our overall health is not going to be as good as it should be. So if you start looking at everything you do with that lens of health and health equity, we're going to be really a healthier state and a healthier city.
Right. You're the commissioner of the Minnesota Department of Health. So what does it do? What does the Minnesota Department of Health do, and what kind of programs are provided by the Minnesota Department of Health?
Well, the Minnesota Department of Health was actually created in 1872, so over 140 years ago. And it was created because we knew that there were environmental conditions that were affecting people, a lot of infectious diseases at the time. Poor sanitation, poor food, and so we got the health department was started to address those environmental conditions. And for many years, that's what it really focused on: clean water and clean food, and then started doing a lot of the vaccine preventable diseases with immunizations.
Sure.
And that is still a core of what we do. But we also recognized, as we got away from acute diseases, infectious diseases, and injuries, and into more chronic diseases, that we had to do a lot more education to folks, a lot of more disease management, and a lot more prevention activities related to lifestyles. So about physical activity and nutrition and tobacco use and alcohol use and sexual behavior, a lot of things that we had to do with that. So we started having some services related to regulation, like regulating restaurants and regulating water supplies, but also in terms of education and educating people and educating the community about behavior practices. And then recently we've discovered that it's really the policies that are in place that impact behaviors. So we started working on policies like tobacco policies. If we can make it harder to use tobacco in indoor spaces, tobacco use will go down, and we found that with the Freedom to Breathe Act. So public health was engaged in a lot with the tobacco policies and alcohol policies, substance abuse policies. So those are just some of the things that we do. So we have 8 district offices throughout the state. We have 1,400 employees. We have people all the way from people who regulate nursing homes and hospitals to inspecting restaurants and pools and lodging facilities, to epidemiologists who are surveying for infectious diseases throughout the state, to public health nurses who are doing home visits to help families parent better with their infants. A whole variety of factors like that throughout the state.
Michael, you're the communication director. So Dr. Ehlinger talked a little bit about more education to the community. Tell us a little bit about some of the work that you're doing in terms of helping the Minnesota Department of Health to educate the community around issues.
Sure. Well, a big part of what we do actually is done by a lot of the programs and units. They, in many cases, have their own outreach teams and people within the divisions who are able to do a lot of the direct community relations work. But one of the things we're trying to do as an agency and get better at is this idea of speaking in plain language. I think one of the things that turns people off to government or any organization that has a lot of specialized knowledge is when that organization isn't able to communicate in a way that really, that resonates with the people that they're trying to help. And so one of the things we're really trying to do as an organization is make sure that when we communicate, we're doing it in a way that is using plain language, words that people can understand, but just also, talking with them about what matters to them. It's not just a matter of trying to push off a whole bunch of knowledge onto people, but also kind of listening and hearing what's important to them and making sure that we are paying attention to that. Because I think if you don't do that, people start to see that and they realize that, well, this is just an organization that's trying to push an agenda. But if you're trying to build a relationship and really help people over time and over the decades, I think that having that two-way communication is very important.
Commissioner, how can people access the Minnesota Department of Health? I mean, you've got a lot of resources. I mean, there are people that might want to find out more information. What can they do?
Well, certain public health is an enterprise. So we have federal public health, the Centers for Disease Control and Prevention, state health department, and local public health.
Sure.
So depending on what people's needs are, they can go to different levels of that enterprise. Certainly, we work really closely with our local public health agencies. So there are public health agencies in all of the counties and the bigger cities throughout the state. So that's where you have a local issue related to public health, that's where you would go. If you need to have something from the state, be it data or things related to policies or state issues, we certainly have a website that people can go to where we have all of our information. Certainly we have call numbers that people can telephone to check on, get information. So those are the ways, that you can access any kind of service from the state health department.
Okay. You started down this track a little bit earlier when you started talking about disparities. And one of the things that's been happening in the news lately is that there's been a lot of comparison to Minnesota in a variety of different ways. In fact, recently somebody was saying Minnesota was lower than Mississippi in some areas. And let's talk about disparities here. I mean, you and I had this conversation a little bit earlier where it's amazing to me. It's shocking to me. It's saddening to me. I mean, there are a lot of adjectives that I could use for this huge gap in the disparities between communities of color and the majority population. I know that you've done a lot of work, so let's get into that.
All right. So let me start. This actually gets at part of what public health is.
Okay.
The Bill Foege was the head of the Centers for Disease Control and Prevention. He said that he had this sort of framework that the philosophy behind science is to discover truth. The philosophy behind medical care is to use truth, those data, that information, to treat individuals. And the philosophy behind public health is social justice.
Okay.
So the frame of public health is social justice. And for me, that means everybody has their basic needs met and nobody benefits at the expense of somebody else. That's sort of my definition of social justice. Mm-hmm. And what public health serves at is sort of the conscience of our health system, broadly defined health system. So one of the definitions of public health that I use is public health is the constant redefinition of the unacceptable. And when we see the disparities in health outcomes in this state, that is unacceptable. When we see infants dying in the African American community at 2.5, 3 times that of the white community, that's unacceptable. When we see the incarceration rate for African American males being 10 times that of their white counterparts, that's unacceptable. When we see rates of all sorts of diseases and conditions that are 2, 3, 4 times that of the white population, those disparities are unacceptable. So that's why we have identified health equity as a center focus in the Minnesota Department of Health, because we see disparities that are greater in this state than in many other states. And given the fact that we have an increasingly diverse population in the state, when I moved here in 1980, we had 2% people of color and American Indians. We're now up to close to 20%. Mm-hmm. And 35% of all second graders are kids of color and American Indians. We are becoming an increasingly diverse state. And unless we deal with those disparities, we're not going to be a healthy state. Because as Paul Wellstone said, we all do better when we all do better. And the reciprocal of that is we don't do as well. If some people don't do well, none of us do as well as we could. So that's why we're focusing on those disparities. And really the center point of what we're trying to do is advance health equity and optimal health for all. We want people to be as healthy as they possibly can be, and we really want to reduce those disparities as much as we can.
How did you develop your worldview?
Well, certainly, I early on in life, when I went to a Green Bay Packer football game when I was 8 years old, and at that point in time, back in 1953, the kids could wander around the field, and I wandered behind the Green Bay Packer bench, and I saw this halfback, Bobby Mann, first African American I ever saw. So when walking home with my dad from the Packer game, I said, "Dad, I've never seen anybody like that in my life." And he said, "Well, you don't see very many here because they can't live here during the rest of the year. They can only come and play football, and they have to live on the outside of town." And I said, "Dad, that doesn't seem to be fair." And my dad said, "Ed, you're right. That is not fair. But that's the way things are right now. Perhaps your generation can do something about that to deal with this unfairness." And so that early on in my life, I realized that there were some inequities. My mom, grew up on a farm, and she saw the fact that communities had to come together to really hold each other together. And so when people suffered, people had to come together and deal with that. So a whole idea about community work and keeping people healthy. So the idea of fairness and the sense of community really was a value that my parents gave me. And so also, when I started in medical school, Michael Harrington just wrote the book, The Other America, in 1962. And it was the book that started the war on poverty from John Kennedy. And it was that book that said we had 40 and 50 million people in this country, the wealthiest country in the world, that were living below the level of human decency. It really struck a chord with me and the professors that I had, saying this is what health should be doing, is eliminating those disparities. So it's been a core of what I've been doing since early childhood, but also enhanced by some of the health training that I've gotten.
Well, I think, and I said this to you earlier too, I think through our observation, many of our observations, we're glad that you are a commissioner, just so you know that.
Thank you.
I'm saying the public.
I'm pleased to be commissioner because it's one of the best jobs I could possibly have.
So let's go back to the issue of disparities. I think that when we talk about that, it's a very sensitive topic, and it's one that people want to engage in. I'm gonna phrase it like this, not with the intention of pointing fingers, but who or what is to blame for us having such a huge disparities in this state?
I mean, and that's a question that probably doesn't have an answer that is totally accurate. I think we all have some role to play because all of us are engaged in creating, as I said, the conditions in which people live and work and go to school. Mm-hmm. Certainly, there are things that have been put in place, like policies that have disadvantaged some populations over others. Mm-hmm. And we've, in our Advancing Health Equity report, after talking with people throughout the state, identified structural racism as one of those factors that have led to the disparities, because it's the policies that forced people of certain communities to live in certain places, to not have educational opportunities, to not have economic opportunities, which we know income and education are huge factors related to health. So a lot of it is the policies that were put in place, and those policies are really because of the political will of a community. So those didn't end up in place because just by one or two people. It's because a society said this was an okay policy to put into place. So I think we all have some role to play, and we have some blame if blame has to be laid anywhere. We all have some role in this. But I'm really saying, all right, what do we do now without saying, some of these things have happened. They may not have happened intentionally, but they happened. It's not about intent. It's about outcomes that we're really looking at. So we're really looking at the policies and the systems and the environment, the social and economic and physical environment that really impacts people.
Michael, what is the challenges of doing your work? I mean, you're director of communication. You've got to please all these people. If it's not right, they're going to look at you a little bit, right?
That's right.
What's some of the challenges of your work in terms of promoting or presenting health to the community?
Well, there are a lot of different challenges, and it's a very enjoyable job, I'll say that, especially when you're working for an organization where you feel like at the end of the day you're able to really make a difference. I think that really helps. In terms of the challenges, I think it's difficult, especially the way that information works these days. There are so many different channels of information. There's so much access. People have the internet, they have radio, they have all the traditional media outlets, but then there are all these other ways that people get information now. It's getting very difficult to kind of punch through that mess of information that's all out there and get your message through to your audience. And so you need to be more creative. And I think part of what the solution to that challenge is, like I was saying, try to think more from the perspective of your audience and have a little more empathy and think about, what are the issues that matter to them and how can we make sure that our message is relevant to them. If you're trying to push a message out that doesn't matter to people, you're not going to be successful no matter how creative or clever you are. But if you have a message that really matters and you work hard and you're creative, I think that's a way that you can kind of deal with that and still get your message across in that chaos.
I think Michael's area gets at probably the biggest problem we have about communication. It's really, what is the story? What is the narrative that's out there? And changing the common narrative in our society about health, it all springs from the worldview. You talked to me about my worldview. The worldview that we have in this country is that rugged individualism, pull yourself up by the bootstrap, reliance on the marketplace to solve all the problems, that small government is good government, that the smaller the better. That worldview leads us to the narrative that if everybody had good medical care and they made good choices about diet and activity and substance use, we'd all be healthy. That's the common narrative.
And that's not true?
That is not true. We know that medical care only accounts for about 10% of our overall health, and yet it gets 95% of all of our healthcare dollars. Most people just assume that, as Michael said earlier on, if I just go to the doctor, that's going to make me healthy. No, that treats disease and illness. It doesn't make you healthy. The other, about 30% is behaviors, but many of those behaviors are impacted by where you live. If you live in a community that doesn't have good schools, it's hard to make the choice about having a good education. If you live in a community that has no access to fresh fruits and vegetables, it's hard to make that choice. So sometimes we always talk about the healthy choice being the easy choice. We're trying to have the healthy choice be a possible choice. So the change the narrative is probably one of the biggest challenges because everybody wants to go back. I hear it all the time. If people just made the right choice, or if people just had access to health care, we'd be a healthy society. That's not the case. We need people to make good choices, and we need good health care, but really probably 90% is really about the environment in which we live. And so we're trying to change the narrative. So our communication strategy is, how do we change that? Because that narrative has been around for 50, 60 years, and so it's hard to change that common narrative to one that, hey, it's really about the socioeconomic conditions in which people live and work and go to school.
Yeah. It's interesting because whenever I make a presentation, I tell people, I said, look, I'm up here to talk about health, but if you look at me, you can tell I like hamburgers.
Nothing wrong. The commissioner and I have had a number of conversations about that. I have a bad habit of occasionally having a soft drink, and I sometimes will bring it into his office, and he says, in moderation, that's okay.
Thing in moderation. So I go around the state pitching horseshoes.
That's right. Okay.
And talking. They pitch me ideas about health. And usually on our way back from, Thief River Falls or Crookston, we will stop at a Dairy Queen.
Dairy Queen. Okay, that's good. I understand you have to have some kind of
everything
enjoyment
in moderation.
Yeah. We're learning that. But I think it's part of the challenge that we're having is that, we have a lot of information. And it's how do you get people to really, as you say, enter into the conversation? How do you get them to change the narrative in their heads? And how do you, as a community, begin to develop a story that fits you? And how do you change the myths into truths? And it's very, very difficult. You also talked a little bit earlier. The movie Unnatural Causes was a great DVD, I don't call it a movie series, in terms of the health of a community. Why is that particular series important for people to watch?
Well, it highlights the fact that zip code is more important in determining your health than your genetic code. People just assume that, your genetic code is really important in dictating what your health is going to be. Yeah, it's important, but it's not as powerful as your zip code. That where you live matters. It makes a huge difference in your health. And where you live is impacted by decisions that were made many years ago and some even current about how healthy that is going to be. Air quality, water quality, schools, safety, transportation issues, stability of housing, economics issues. That is all determined by where you live. So zip code is really important, and Unnatural Causes really pointed that out in really graphic terms.
Okay. So let's talk about some specific issues, some specific topics that are important to the community. I'm going to start with the first one that I like. It's fatherhood, children's health, maternal child health. What are your thoughts? Where are we at in Minnesota with that?
All right, so let's talk about some of the things that link to all of those things, and that's income. So one of the things for me, in the 4 years that I've worked with Governor Dayton as part of his cabinet, I think we've had a lot of public health achievements, but the greatest one, I think, is increasing the minimum wage. You know, people say, well, that's an economic issue. That's not a health issue. Well, increasing the minimum wage, if you can move somebody from the lowest 20% of income into the second lowest level of income, you know, from under 30,000 to above 30,000, you can increase their life expectancy by 3.5 years. Huge impact. We also know that if you have more income, you can do a better job of being a parent. You can do a better job of being a citizen. You can, because you take away a lot of the stresses that are there. So a lot of times, you know, we talk about, you know, people not doing a good job of parenting, but a lot of times they're under a lot of stress. They have to have 2 jobs, 3 jobs. They don't get any benefits. We also know that's what we're working on now is that paid leave. This was a big conversation in the city of Minneapolis, that if you can and we're the only country in the world that doesn't have paid maternity leave, you know, so that the mom can stay home with the baby for 6, 8, 12 weeks, whatever. And we know that 10 weeks of paid maternity leave decreases infant mortality by 10%. Again, people think paid leave, that's not a health issue. That's a huge health issue. We also know that paid sick leave is a huge health issue because if you can stay home when your kid is sick or when you're sick, it's going to help the kid. It's going to help your business. It really cuts down on transmission of disease, a whole variety of factors. So this is a huge issue. But it also points out the fact that the people who don't have access to paid maternity and paid sick leave are usually low-income populations and disproportionately people of color and American Indians. So this is one of those structural racist factors where our system is set up to disadvantage low-income populations of color as opposed to the white population.
So how did you get away with saying structural racism in Minnesota?
Well, one of the things about public health is our job is to tell the truth. And structural racism is not about individual racism. It's about policies that disadvantage some populations over others in a structural way. You know, we look at it even in our own department. So we do a lot of education, and Mike's, his area does a lot of education. And in some of our programs, we targeted homeowners as a way to get information out. It's a very efficient way. It's an effective way, particularly when you're talking about things like mold and radon and lead. We target homeowners because it's an efficient way. But we didn't realize that among the white population, 75% of whites are homeowners, and only 21% of African Americans are homeowners.
Exactly.
That is structural racism. It wasn't intentional, but we disadvantaged a population because they weren't homeowners. So we've changed to look at, all right, let's look at people who living in homes and a different way of targeting them. So we looked at what happened with the Green Line, the Central Corridor Light Rail. When that first got started, the metric of measurement was how fast you could move somebody from Minneapolis to St. Paul. That was the metric that they were going to be evaluated on. Well, the people in the middle of that line, the midway, a lot of low-income and populations of color said, wait a minute, we're being disadvantaged here. So they rose up and said, you are structurally disadvantaging us by that policy that says how fast you can move from one end of the line to the other, disadvantage us. So fortunately, they rose up and said, we need some stops. But that way that policy was initially set was structurally racist because it disadvantaged populations of color in the middle of that line. Same thing with paid leave. If you only target paid leave at full-time employees in higher income parts of your workforce, you will disadvantage people at the bottom who are part-time workers and lower income, which are mostly populations of color. Again, a policy that structurally disadvantages. That's structural racism. So we try to tell the truth. It's not blaming. It's not saying that you did this intentionally, but we say you have to look at the impact it has on populations of color and American Indians if you really want to make just public policies.
How have other states utilized you? I mean, I think that there's probably other states that have looked at some of the work that's happening here in Minnesota. How have they come and approached you to utilize you or to tap into some of the things that are going on here?
Yeah. Well, we certainly have been focusing on health equity, and every state. Minnesota is not unique in its disparities. We have some very high disparities, which is really kind of surprising, as you've pointed out.
Sure.
We're generally a healthy state. Why are they so high here? But every state has some of those disparities. And so people look to us and say, how are you doing this? And why are you, how can you say things like structural racism? And how can you focus on things like minimum wage, which are sort of political issues? Say, wait a minute, no, these are just the facts. Our job is to tell the truth in public health about what are the issues. The policymakers can make choices about all of those things, but we have to tell the truth. That's why our Advancing Health Equity Report has gotten such attention, is because it told the truth about what creates health. But also related to your question about how do we influence other states, I've recently been elected as the president of the Association of State and Territorial Health Officials, which is the organization that represents all health commissioners in all of the states. And I've challenged all of my partners, all of the colleagues, all of the commissioners in other states to really take on this challenge, advance health equity and optimal health for all. So I get to challenge each one of them. And I've challenged them with a triple aim of health equity, saying this is what you should do in your state. You should really expand your understanding about what creates health. That's sort of the first aim. Expand our understanding that it's not just about medical care and personal choices. It's about the communities in which you live and the policies that are in place. Secondly, implement a health in all policies approach with health equity as a goal, which says that you need transportation and housing and economic development and education and the criminal justice system all need to be engaged in creating healthy communities. It's a health in all policies approach. And you have to have health equity as the goal, because if you don't take health equity as the goal, transportation could lead to gentrification of neighborhoods, which would not be an equity thing. And finally, support communities in creating their own healthy futures. Create the capacity in communities to create their own healthy futures, because if communities are engaged, everything is possible. Communities are powerful if they're organized. They can create a lot of change. So we really try to empower communities to create their own healthy futures. So that's what I'm challenging my health commissioners in every other state. And they're saying, well, we can't do that in our state. And I say, baloney, because it may take a lot of work, but Minnesota is not the place where we are now by accident. We've done a lot of work with a lot of communities to get to the point of at least having this conversation.
So let's talk about this, expand the understanding of health. Mike, why don't you join in this? What does that mean? I mean, is that individually? Is that community? I mean...
Well, I think a big part of it is helping people think differently about what gets into health and what they need to be focused on. You know, the idea that I'm just going to make the right choices in my life and then everything is going to be okay. It's just, the evidence, as you look more at what the commissioner is talking about, it's just not enough. There has to be a community around you that's enabling you to be healthy and to really achieve your full potential. If you don't have that community around you that is, reinforcing those healthy habits and allowing you to achieve your full potential, you're just not going to be able to have not only your health maximized, but that of your family and your surroundings. I mean, we're social animals, and we depend on each other. And if we don't have a healthy community around us, it's going to make it that much tougher. I think a big part of it is getting people to think a little bit more broadly. And you talk about changing the narrative. That's really what it is not just a narrative, but even a mindset. When you think about health, it's not just what can I do, what should I eat today, or should I go running for 30 minutes, or should I hit the gym, or whatever. That there's more to it. It's, am I connected with my community? Do I have an opportunity to have a job that's secure and housing that's secure and things like that? And all those things are going to determine whether you're healthy or not.
It almost goes against the American way, right? I thought we were, like you were saying a little bit earlier, John Wayne, Lone Ranger, it's all about me, right? But you're saying, no, we got to start thinking a little bit broader than that about this whole issue around health and understanding more about it.
Yeah, it does go against the common narrative, the rugged individualist.
Sure.
And I'm certainly one to say people need to take responsibility for their actions.
Sure.
But our job as public health workers and as members of our society is to allow people really choices. If you're going to make a good choice, you have to have that as an option. And that's set up by us collectively giving people the option. Other countries do a whole lot better than us in terms of health. We are a very wealthy society. We spend more money on health care than anybody else by a long shot, double the next lowest or next highest in terms of. But yet our longevity, our length of life is declining compared to other countries. Our infant mortality rate is declining compared to other countries in terms of ranking. We're getting worse internationally rather than better because we're the only industrialized country that spends more than half of our total health and human services dollars on medical care. Other countries spend only about a third of their total health spending on medical care, and the other 2/3 on things that actually benefit the community, the public health and human services that impact the public good, the commons that affect everybody.
Sure. That's really interesting to me because I think, like I said, we're talking right about now. You're saying that instead of spending as much money on hospitals or medical services, we're talking about maybe green space or bicycle pathways or.
Right. It's the community environment. We're looking at what's happening in communities, complete streets, safe route to school, farmers markets, green space. All of those things impact the community in ways that really enhance health. And we also find out, which I'm finding interesting as I look back at history, that the time when we started to spend more money on medical care and less on public health, that's when our costs in healthcare started to rise above other industrialized countries. When we invested more in medicine than in public health, our healthcare costs went up, and our disparities started to go up, and our health indicators started to go down. So that's why I say medical care by itself is actually detrimental unless you partner our investments into public health and social services. Medical care by itself cannot treat us into health. In fact, it'll make us worse.
Clarence, my business is all about sound bites. And one of the sound bites I've heard the commissioner say that I think really captures this idea really well is the idea that we want to have the best healthcare system in the world, and we want to have people not need to use it as much.
That'll be interesting. I just say it like that. So how do you, as commissioner, how do you implement health in all policies?
Well, so you have this radio show,
right,
and I have a TV show.
Okay,
and so I've systematically been inviting all of my fellow commissioners to come on the TV show and say, Charlie Zelli, you're Department of Transportation Commissioner. What role do you play in health? Brenda Casilius, you're the Commissioner of Education. What role do you play in health? Tom Roy, you're the Commissioner of Corrections. What role do you play in health? And I've done that with all of the commissioners, and it forces them to think, all right, what's my role in health? And then we talk about it, and then have them on tape saying this is our role.
Right.
But they all come from the same perspective, I think, of what we do collectively.
Sure.
And Governor Dayton really has also that more social justice perspective, and so he expects us to work collaboratively and recognizing that we can help each other do well. So we've got relationships with transportation, working on safe routes to school. Transportation recognizes this as what their job is to do transportation, but they can do it with a health lens. We worked with them in public safety on towards zero deaths, trying to reduce traffic fatalities. It's not just about engineering or it's not just about enforcement, but it's about health, public safety, and transportation working collectively to figure out ways to make our roads safer and moving safer. We certainly work with corrections on health, recognizing that who gets arrested, who gets put in jail is a health issue, and what happens in the prisons and the jails, and then what happens when they come out, that there's a whole connection, particularly now when we know that there are 15,000 kids in this state who've had parents who are incarcerated. And that's a huge health issue, so that we have to work with corrections on trying to mitigate the problems that develop from that. Talking about that, certainly when I go talk with the Council of Mayors or when I go talk to Rotaries or the Chambers of Commerce, when we talk about what creates health, when they start to see that medical care is only a small piece of it, but how they create their societies, their cities, their counties, their state makes a big difference economically and socially, they get it. Intuitively, they understand it because they know in their neighborhoods, if they have safe houses all around them and they have access to grocery stores and good schools and clean water, that makes them healthy. So they get it, and so we're starting to change that conversation. And I think we're getting buy-in from the business community, from the health community, from the education community, from the transportation community, across the board, seeing that they have a role to play.
So let's take that even further, because now the third part of that triple aim is to strengthen the community's capacity What are you doing to do that?
Well, that's why being in this program is so important. I think there's no magic bullet. We've disinvested in our communities over the years. So we have distressed neighborhoods where people just have a hard time just making ends meet, trying to stay alive. And so they're focusing on their own individual survival. We have to have communities. The faith community is a good place to start. Start talking about, we need to be our brother's keeper. We need to start helping out each other out. And when they start finding ways to help each other out, we realize the power that's in that. So like your community clinic, again, it helps to bring people together, start talking about it. Our schools can help bring communities together and start recognizing that if they start to organize and help each other out, they can be a powerful force. Certainly some of our grants that we make are trying to build community and starting our work with local public health to say, how do we engage community in a meaningful way so that we can bring members from the community to be at the table in decision making. So one of the things that I always ask is, when you're having an advisory committee or a task force, who's at the table and who has the power at the table in making decisions and who's held accountable? And so I think it's attendant upon us, particularly in the public sector, saying, who are we working for and are they represented at the table, and do they have power at the table? So we're asking that of hospitals, we're asking that of clinics, we're asking that of community organizations and school boards and park boards and everything. Who's at the table and do they have some power? And so we're trying to say, when do you have your meetings? Is it during the middle of the day when people are at work, or are they sometimes in the evening? Do you have childcare available to help people come? Do you give them food? Because sometimes that's what they need to be able to attend a meeting. So a lot of those things can help to build the power in communities. A long, slow process, but again, it's not just our job. We can support it, but it's your job. It's the neighborhood associations, it's the schools, all have to build that community.
Commissioner, I'm now a baby boomer, and I'm getting to be older or more seasoned. What's the state doing for the aging? I think that population is starting to get a larger percentage of the population. What are you going to do for us?
Well, the healthy community impacts everybody in a healthy way, whether you're a pregnant and parenting mom or dad, or if you're a senior citizen. And we know we have something called the SHIP program, the Statewide Health Improvement Program, where we're in counties throughout the state, and we've been working on not necessarily programs and service delivery, but we're working on policy changes and system changes and environmental changes with representatives from the business community and the education community and the healthcare community and the public health community and the faith community, saying what policies can be put in place to make this a healthier community. And we've been focusing on physical activity, nutrition, and tobacco use as a starting point. And we're recognizing that the same things that we do for childhood obesity related to physical activity, nutrition, and substance use are the same things that'll help prevent or slow down dementia in the elderly. Physical activity, good nutrition, and reducing substance use of harmful chemicals. That is going to do the same thing for the seniors as it does for the kids in terms of making them healthier. So it is universal design. You probably heard about that. You design something for everybody to use it. Well, it's designing universal design for our communities, because if you benefit things for pregnant women, we'll also benefit the elderly.
I'm going to mention 3 topics, and I want you to just kind of give us an idea about where we at in the state with these particular topics, heart attacks and strokes.
Yeah, well, we have the best rates related to heart disease in the country, number 1 in terms of heart disease. And so, in fact, we're doing such a good job in heart disease, it's no longer the leading cause of death in our state.
What is it?
Cancer is now the leading cause of death. Okay. Because we've done a lot related to tobacco use.
Sure.
We've done a lot related to hypertension. We've done a lot related to our hospital system being able to identify and treat heart attacks and strokes very quickly. So we're doing very well with that. We've got a lot of good disease management and a lot of good prevention. So this is one of the successes. Certainly a long way to go. But again, there are some disparities. Overall, on average, we're doing well. But populations of color and American Indians don't do as well with heart disease and stroke as the white population.
Okay. Infant mortality.
Again, we are one of the best states in the country. Some years we're number 1 in terms of having the lowest infant mortality rate in the country. But again, the disparities here are huge with the African American community and the American Indian community. And those haven't gotten better. In fact, the infant mortality rate of African Americans in 2011 still had not reached the white rate in 1980. So for me, those dates are important because I moved to this state in 1980, and infant mortality and disparities was one of the issues I dealt with. I became health commissioner in 2011, and when I looked at the data, realized that the African Americans had not reached the infant mortality level of the whites in 2011 as the whites had in 1980. That's one of those things that's unacceptable. The constant redefinition of the unacceptable.
Sure.
That to me is unacceptable. In this state, one of the healthiest states in the nation, with all of the resources that we had, and we also have the best medical care system in the country. We're rated number one in health care, so it's not about health care. I mean, if you want good health care, come to Minnesota. We've got the best health care system, I believe, in the world. But health care is not going to treat us into good health. It's all those other social determinants that are there that we really have to deal with.
So what is the conversation that we need to have with the community around health equity? I mean, what do we need to say to them? I mean, how do we really talk about this issue of health disparities in a way in which people can really be engaged in the conversation, or to think about, how important this is? I mean, I believe that everyone wants to be healthy. I mean, everyone wants their children to be healthy, but some way we're missing.
Yeah, I would turn it around,
Okay.
not to say what can we tell the community. Actually, what can the community tell us about health equity? In fact, the power of our Advancing Health Equity report was that we did not write the report. The community wrote the report, and we did it this way. We went out throughout the state and had thousands of interviews with people, and from that input about what's going on in our state, that's when we wrote the report. Then we went back to the community and said, do you hear your voice in this report? And if they said, no, we didn't hear our voice in this report, we went back and rewrote because we really wanted it to be a community report. And the power of this report, it's won some awards in terms of its groundbreaking work, and it's also being looked at from other states. The power is because it was the community's voice that was being reflected. So I, first of all, say, let's have the community be able to give voice to what's going on. They identified the fact that there was structural racism. They identified it. They named it. We put it in the report. And that has allowed them to then come forward and say, all right, you put it in the report because we were there. Now, this is how we have to deal with it. So it's really that's where if communities are empowered, we are just partners with them in really identifying the solutions and making the changes happen.
How can you're opening up the door for people to be able to share with you what they're thinking. How is it? What's the method that we need to do if people have an opinion, have the thought? What should they be doing? They should write you a letter. I know that would help.
They first of all, they need to talk to their neighbors.
Okay.
They need to talk with other members in the community and say, it's not just me on this little house or this apartment, but it's my whole neighborhood. And we've gotten together and we've talked, and I am representing that. I legitimately represent that community, and this is what we need in our community. And you certainly can go to the state health department, or you can go to the legislature, or you can go to the city council, or you can go to the school board.
Sure.
If people come together, and certainly there often needs to be a spokesperson.
Sure.
But if that person is just by him or herself, it's not as powerful as saying, I have 17 African American churches that have the same feeling, and we said we need this to move forward. That's a powerful message. That's where I think a lot of the work needs to happen, with people coming to the table, saying we need to be represented at this table, and we need to have some power in making some decisions. That's where I think change is going to happen.
Right. You know what? You've really expressed yourself well. What's the biggest challenge of your job?
What's the biggest challenge? The biggest challenge is to not get pigeonholed into, health departments are only supposed to do restaurant inspections, and they're only supposed to do work on clean water, and they shouldn't get involved in these broader issues.
Sure.
Because public health, your swim lane is such. It goes back to this whole challenge about changing the narrative. We're about the conditions in which people live.
Okay.
And so the biggest challenge is to say it's not just about medical care. Medical care is important, but it's brought all of these other issues. And then trying to help change those conditions when we invest most of our dollars in medical care. So all of the work that we're doing about health, not all of the work, most of the work we're doing about health equity really doesn't have any financial support. So we're doing this by patching things together from a variety of places. We need to invest in the public good, and public health is about the public good. And we spend less than 1% of our overall general fund dollars on public health. Like it's 0.7%.
Wow.
Very small amount. We're 46th in the country in terms of state funding on public health. So to do the work that needs to be done without an investment of resources, human and financial, is really quite difficult. I think we're doing a good job with what we've got, but that is certainly one of the challenges that I face is how do we have the resources? Because the forces out there, the resources that are going into healthcare, they're going to have to change, but it's hard to change that with the limited resources that we've got.
So, Commissioner, if you had 2 minutes and you could say whatever you want to the community about public health, about its need to be engaged in the process, you can rebuke him if you. No, I'm not kidding. No, don't rebuke him. No, don't rebuke him. But what would you say to him? What would you say? I mean, passionately from your heart. I mean, and I think that you can. But what would you say to him?
Well, it's the things I've been talking about here. The public health is about community. Health is about community. And so people have to be engaged in their communities in things that are going to change the conditions in which they live and work and go to school and go to church. They have the power if they get organized. I see community organizing as a public health tool. That's why I'm really glad as we're working with changing the narrative.
Sure.
We need communities to be engaged in changing that narrative. We need communities engaged in changing the policies. We need communities to be engaged in working with their policymakers at the local, state, and national level. I would say if you want to be healthy, if you want your community to be healthy, you have to be engaged. You personally or your family members or your neighborhood, and everybody has a role to play. I also tell them that their job, your job, is just as important as my job. I have a different job to play than you do, but I can't be successful unless you're successful running your community clinic, running your TV or your radio show, getting the community engaged. We all have a role to play, and we have to work collectively to do that. And we have to change that narrative, that it's not just about the rugged individual pulling him or herself up by the bootstraps. This whole idea about you can do it on your own or the family bubble, that family can do it, is not accurate. We need each other. We live in a community, and the community supports our health.
Michael, last words to the community. What would you say to them?
Well, I think one of the things that is really important for people to realize is that this idea that you can make an impact and that it's worth trying, I think that's something that's really important to convey. I know that there's a lot of cynicism out there about, is it really possible to make change? Are people going to listen to me if I go out there and talk? And I see every day the power of individuals and groups working together on not just health policy, but in a lot of different areas. And I think we all owe it to not only ourselves and our families, but to the people who are going to come after us to try to make things better in our neighborhood or our community. But to not lose hope, because there is a lot of opportunity for change if we work together and if we're smart about it.
Well, Michael, I want to thank you, and Commissioner, I want to thank you for being a part of our show tonight. Really, it is an honor to have you on the show, and I'm glad that we were able to work with Dr. Wendy to get such a wonderful guest to be a part, to talk to our community about the issues of public health, about maternal child health, and about issues that impact us. And so, listeners, I want to thank you for listening to us. And this concludes our little series with the University of Minnesota Public School of Public Health. But it doesn't conclude our work. There will always be others who will be coming ahead and coming on and talking about issues that impact our community. This is Community Health Dialogues. Our purpose, our goal is to make sure that the community enters into the conversation and that they have access to resources. So thank you for listening to us. We will talk to you again next week. Have a great evening.
Thank you for listening to Community Health Dialogue, sponsored by North Point Health and Wellness Center. Join us next Monday from 6:30 till 7 for more discussions for a healthier community.
KMOJ, Minneapolis, St. Paul, bringing unity to the community. 89.9 KMOJ, the People Station.